Thank you, Pat, and thank you for introducing me to IOM and for the invitation. I'll give you a disclaimer. I am a private citizen. I'm not an engineer. I'm not a doctor. I'm not smart like you guys. What I am is observant, and I've been working with the likes of Pat Catalano and a whole bunch of smart people. And my 47 years of entrepreneurial background is all about problem solving, and I've built several companies and sold them, and I'm now in the process of going broke by assigning myself a nonprofit task, the likes of which we have in front of us. So I feel like I'm preaching to the choir. You guys know everything that I'm about to say. I'm here really as a translator of sorts, a private citizen translator. I've developed a protocol called the first 1,000 days, which starts from conception and goes through age 2. And we've been several years now developing this protocol, which includes a wellness algorithm, which I would like to suggest to you is just simply a framework, because I'm all in favor of the Affordable Care Act, and what I see is a trend toward this patient-facing or patient centricity, because I think the missing link that I have seen out there are all of us when we're in the community of requiring health care. We rely on the expert, we rely on the doctor, on the hospital, all of the people that know more, we think, than we do. And when I apply this, or when I see this being applied to pregnant women, particularly, I was particularly shattered, I guess, in a way, to learn that of the 4 million live births in the United States every year, 2 million of them are to WIC women and their families. I have a vague understanding of what a WIC woman looks like. Certainly from an economic standpoint, she's has less income than I used to have. I have no income right now, so, I think one of the challenges that we have is, as you have just indicated, how do we recruit a woman preconception? Because it's fine for me to say we have a protocol from conception to age 2 that we call first 1,000 days, but it's quite another story to interface with and engage a woman at conception. It's pretty much impossible unless you're the sperm donor. So I think it's one of the things. I'm from Oregon. Kitzhaber is the governor of Oregon. He's an MD. I think Oregon is one of the out-of-the-box thinkers in the country. I have spent the last year and a half lobbying state legislators, talking to them about first 1,000 days, talking to them about what our protocol looks like, talking to them about getting health care reinstalled in K through 12. That, to me, is a place where we could provide some additional sex education. So I like the whole reproductive health idea. Planned Parenthood will play a role in how we find and recruit women. WIC will also perform a role. But unless we can, as a country, unless we as a society can reframe when we begin wellness, or particularly prevention, I think we are toast, absolute toast. We cannot start toward the end of the first trimester or later than that. We need to do something. We need to be somehow or another, all of us together. What I'd like to do is invite all of you to somehow or another connect with me, and I'll connect with you. And I'd like to be on some type of an awareness campaign that we get the word out to our women in the world, our men in the world, our kids in the world. If kids can help parents attach their seatbelt, why can't kids help moms and dads or moms and boyfriends do a better job in reproductive health. So I do like the idea that I've heard before that even if we miss a woman in the first trimester or second trimester, we need to be doing something very proactively for her ahead of her next child. It is very, very important. Our first 1,000-day program is all based on the science, relatively new science, as I understand, maybe 30-ish years old, called DOHAD, Developmental Origins of Health and Disease. So it's about fetal origins, and again, back to my disclaimer, I don't know what I'm talking about, but it seems to make sense to me that the fetus is biologically programmed by mom from the very point of conception. So if that is in fact true, and I'm told it is true, then we have to be there somehow or another, because the pre-programming of a WIC woman, as I understand, has 4 times or so the incidence of diabetes, has a higher incidence of obesity and other chronic conditions. So what we have is a society that is filling the pipeline with those very people, the 40% of the people that are creating 84% of our healthcare costs. It is reversible. It is absolutely reversible. I think I'm standing here preaching to you as the choir, to use that analogy, with the cure for type 2 diabetes, with the cure for obesity. But it's going to take political will, it's going to take courage on our part, it's going to take courage on the characters that just walked out of Congress today on this stupid stuff, that they can't get their arms around certain things. How are they going to get their arms around this? I'm not interested in a debate over whether I'm pro-life or pro-choice or anything. What I am is pro all of us as a society, and what we are looking at, if biological programming is in fact the case, and I'm taking my I've been a student of diabetes for the last 18 years. I developed a continuous glucose monitor for people with diabetes and sold that company to Bayer Healthcare. So it's from that lens that I know a little bit about diabetes. I know that there's a huge behavioral science problem that we all have. I know for me, when I come up with my New Year's resolution about losing weight, except for this year. This year I've lost, I'm standing here a shell of my former self, in fact. But those New Year's resolutions go out the window. And so one of the things that underpin first 1,000 days, it's a little bit of David Oles, it's a little bit of Teamlets, it's a little bit of stuff out of University of Washington that's team care, mom care. We've taken a lot of evidence-based studies that are diabetes and depression related. We have applied them. In some cases they've already been applied to pregnancy, but in most cases we're applying them to a new population, which is not only WIC women, but I think what I'm working on, and I think what I hear you guys working on, is actually a new standard of care for maternal and child health. I like that a lot. I like that a whole lot. So there's a behavioral science piece that's sort of the missing link, that somehow or another, when I think about what David Oles has done, we're in the first 1,000 days protocol. I think I'm right here, but correct me if I'm not. I think that the reimbursement rate for contact between the pregnant woman and her caregiver, the OB-GYN and others, is 11 10-minute visits. I don't believe that's enough time to spend with the most important thing in our lives, and that's creating another human being on the planet. What we're all about is increasing the frequency and the duration of time. I sort of like 40 hours, 40-week pregnancy, 40 hours, on top of the 11 10-minute visits or whatever else comes along with regard to health care delivery during that 40-week period, and postpartum with pediatricians, et cetera. So that's one of the key elements of our program. We do it through a mental health approach, or we plan to do it, I should say, through a mental health approach. It's creating small groups. We would encourage each pregnant woman that we can engage, we can recruit and engage to assemble her own small group. Include her mom, include her grandma, include the husband if there is one, or the significant other. Include perhaps a teenage kid or a neighbor or whatever. Have a small group of 6 or 8 people, and they meet weekly and they talk about the weight gain that you guys are talking about in this workshop. They literally work on goals and objectives that would be healthy goals and objectives. Primary operative word in my foundation is the word contact. Contact Wellness Foundation. Contact is the human contact that I believe is one of the missing things in our society these days, not just in pregnant women. People beat the shit out of one another, it seems like, on the street, in Congress, all over the place. We are not a friendly society. And when you take this objectification and now you surround a woman with it and create additional stress, it translates directly through, again, biologically programmed, directly through to the kid. So it's not only food as nutrition, which I would suggest are whole foods, not Happy Meals. It's good exercise, and it's also contact like embrace. It's touch. And that's what we would promote or hope to promote in First 1,000 Days with this greater frequency and duration of time. So in the last year, we made an application to CMS a year and a couple of months ago that was a $28.5 million application to take First 1,000 Days to market in Oregon in only 33 of the 36 counties of Oregon. We excluded the 3 main metropolitan counties that surround Portland because of their complexity. We wanted to, but the 3 main counties around Portland represent half of the pregnancies in the state. But we wanted to dip our toe and thought we might be more successful if we were in the more rural areas. And there's plenty of towns in Oregon that are 100 or 200, 300,000 population. So there's lots of complexity outside of the main metropolitan area. We were not successful in that $28.5 million grant application. I looked through all of our competition. I wasn't terribly impressed with what beat us, but so be it. You know, I'm like a bulldog with a bone in his mouth. I'm going to probably die in my soup one day trying to do good work like you all are trying to do. So I need your help. I want you to join me. I'll join you if you are willing to join me. We're out there continuing to look for funding. I keep being told, don't think so big, don't think $28.5 million for half the state of Oregon. When you do the whole state, by the way, it is $50 million. And the cost of our community-based intervention is $1,000 per woman on top of what's reimbursed. $1,000 per woman. So there's $24,000. Now you do the math and you say, well, wait a minute, if we were totally successful and penetrated if we enrolled every one of these women, that would be 24,000 times 1,000. That's only 24 million. We have a second $1,000 that we would plan to tack on here, and that's a 529 savings bond for the baby, as an incentive for the mom to be motivated to pay attention to her goals and objectives for her 40 weeks of pregnancy. We would think that $1,000 529 savings bond would grow over an 18-year period and be available for the child to go on to higher education or vocational school or whatever. I like to think that the $1,000 could grow to about $15,000. Everybody that looks at it says, no way anymore in our economy are we getting anything but a few percent return on investment on somebody who buys a bond. So suggest to you that for the state of Oregon, as the demonstration state, the model state that I hope to continue to work with, and to one day develop a large demonstration in the form of an entire state, that we would then trot across the rest of the country as a for-profit activity. As a for-profit activity, because we have a toolkit, and it's a toolkit that includes glucose monitoring, A1C monitoring, BMI measurements, et cetera, blood pressure monitoring. And within this toolkit, and automated hovering is what we call it, which would be cell phone. The only way the $1,000 community-based intervention pencils out is we have to elevate the facilitator that we would add to those small groups up above 48 women. So if we've got 24,000 women that we're looking to serve, we're going to have several hundred facilitators that would be hovering above them. They would meet initially once or twice to help the group assemble, create some initial goals, and then by cell phone and electronics would be interfacing with the woman and her small group, hopefully. We have no idea if we can even encourage a woman to assemble a small group, frankly. I mean, it's a good idea. I have lots of good ideas. Not all of them do they always manifest themselves in something that works. But that's what we're all about. We're all about coming up with alternatives, different solutions. So what I'm referencing here and beginning to now say, and I'll try to conclude very quickly so that we can have more time for some Q&A here. But we have developed, and you'll see in your packet, a white paper, and it's cut into two halves. One is the first 1,000 days. The second half is a social impact bond that we call a birthright bond. And that birthright bond is a financing mechanism for the first 1,000 days. We would imagine selling through Goldman Sachs and various other bond sellers from Wall Street, we would imagine selling in the state of Oregon $50 million worth of bonds per year over a 10-year period. That's $500 million. And we would use the funds to do the community-based interventions. Now, probably wouldn't be $500 million or $50 million a year, because we're not going to actually recruit every single pregnant woman in the state. So if we were wildly successful, we would recruit 30 or 40 or 50%. In any event, this is the kind of out-of-the-box thinking that perhaps I'm introducing to you today. But it makes total sense, because if what we do through biologically programming and these small groups and first 1,000 days community-based intervention, where we are literally bringing neighborhoods and families back together to do the very most important thing ever in our lives, and that's build a new baby. If we are successful in encouraging the mom to moderate her metabolic function, to normalize her glucose, to exercise more, to hold her, touch her, to be kind and generous and loving of her, this translates through to the baby. The baby is not born predisposed with diabetes or obesity or other chronic conditions. And I can't exactly state every figure that's in this white paper, but there is an enormous savings. If you look at the gap between the 40% of the people that are creating 84% of our costs, it's $2 trillion. If we make but a small dent in that, and those dents are the savings, all I propose in the social impact bond, the birthright bond, is to take 10% of the savings and pay back the bondholder. In a discussion with Goldman Sachs 3 weeks ago, they said, well, this is a good idea, but we're sort of risk averse. And we think that even though this is a good idea, you better go out and find somebody that will guarantee at least a payback of 80 cents on the dollar, or it's not going to be sellable to a normal bondholder or somebody that would like to buy a bond, let alone get a return on investment. Go find a guarantor Basically, they're saying, go to Annie E. Casey or Gates Foundation or Robert Wood Johnson or any of the number of just very huge nonprofits out there and have them guarantee the bondholder, because we don't know if this is going to work yet. And I can't very easily stand in front of any stupid Wall Street guy and tell him, yep, this thing's going to work. I'm convinced it will work. You guys probably know better than I that this is not an easy challenge at all. Not easy one little tiny bit. So we have an uphill challenge for us as people, as lovers of each other. I'll leave you with one story, and we'll have time for some questions. Karen, are you here, Karen? Okay. Are you proud of me? I'm leaving some good time here. Okay. My wife died 18 months ago. She and I were married for 47 years. She contracted breast cancer in 1994. 1999, she was cured. She had a lumpectomy, radiation to the site, 5 years of tamoxifen, was gone in 1999. In 2007, it came back, metastasized to bone. We got 4 years in. In the last month of her life on the planet, we were introduced to hospice. So she died at home. It was the most wonderful experience of my life. I'm not sure at some level, she was on morphine, increasing amounts. So, but the family and I had the most wonderful experience with hospice. What I'm here presenting to you today is first 1,000 days is hospice plunked down at the beginning of life. End of story. Any questions? I'll be happy to try to field them. Yes, sir.